Hi, this is Mark Duncan, and I'm one of the clinical directors at Las Vegas Institute for Advanced Dental Studies. And I want to talk to you today about the power of dentistry and what really dentistry can do for you, how you can use dentistry to open up not just a new paradigm in your life, but in the lives of your patients, how through comprehensive care you can impact patients in ways that in dental school, quite frankly, we just didn't appreciate. So we're going to talk about the impact of comprehensive care. And you know, I remember back when I was in dental school, I went to really a very good dental school, Oklahoma, and what we were taught, probably like many of you, is that they could teach a monkey to be a dentist. What we needed to learn how to do was be a doctor. The problem is, we never really learned how to do the doctoring side of dentistry. We went in so many ways to a trade school, and we weren't able to see beyond what we were taught. We can go in and fix a problem with the tooth, and we can go in and find some bleeding in the gum tissue, and we can educate our patients. We can help our patients to see why they might need to have a new set of dentures. But to be truly a comprehensive physician of the mouth, of the structures of the head and neck, of the entire system, to be able to help our patients to explore how dentistry is tied to the rest of their body, that takes some more learning. And that's what Las Vegas Institute has really become about. LVI has led the way in comprehensive diagnosis, in care that's delivered to our patients through thorough evaluation, taking a detailed health history and a detailed examination, and then helping our patients to understand why that's important and what they can do with it. So dentistry is about a lot of different things, and as we're going through how you treat your patients and what it is that you're after, one of the biggest things that we need to remember is that really it's about the quality of life. What we as dentists are really there to provide for our patients is quality of life questions, quality of life answers. And if you can help your patients to see why they want to invest in thorough health care, why they want to afford helping them take care of their mouths, why they want to take care of the things that are important and not just the things that they can see. You help your patients to achieve that, then you've helped them to achieve a quality of life that they can't get any other way. So I want to walk through a couple of cases with you and just talk about my experience going through as a baby dentist coming out of dental school and as a young dentist trying to learn how to do more comprehensive dentistry, and then a little bit about how I see the mouth now. And we'll start with the tail end. We'll start with a patient like Judy, and I want you to reflect back on what you would have thought about if you had met Judy as a first-year graduate right out of dental school. So Judy had several issues going on. When you look at what Judy looks like, you know, an average patient, middle-aged woman, she had a number of symptoms, and those symptoms are things that would come out on a health history, but we don't really pay attention to them. Certainly coming out of dental school, if she reported to me that she had a history of paralysis from polio, I'm a dentist, and I don't fix polio. I don't even treat paralysis. It's not something that's on our list of things to worry about. We treat the white, hangy, downy things, and that's kind of what our focus has been. If I can diagnose decay on an x-ray, if I can see frank decay on a tooth, I can help you to fix that, and I can fix it with you in a number of different ways. But paralysis, that's not something we look at. Dysphagia is another of those issues. I was fortunate to do some research projects when I was in dental school. It's one of the multiple jobs that I held to get myself through school. And I learned about dysphagia. We worked with the medical student in the geriatric dental program at University of Oklahoma, and so I knew full well what dysphagia was about. But swallowing disorders as a practicing dentist, it's not something that we really talk about a lot. Loose teeth is a dental problem, and that's something that right out of dental school we finally hit one of her symptoms, one of the things that she complained about that would be important. And if you've got loose teeth, well, by gosh, we're going to get a look at your gum tissue health. We're going to find out how to get your gum tissue healthier so we can tighten those teeth back up. But what if there isn't a perio issue? What if the loose teeth is from something else? Now, there are other issues that you run into as a dentist. Bruxism is one of the big ones, and I was taught in dental school that it's kind of like earlobes. Some people do, some people don't, and there's nothing that we can do about it. I was taught in dental school that we don't know what causes bruxism, and we don't know how to fix it. So if you are a grinder, if you're a bruxer, if you're a clencher, you're stuck with it for life. So on a health history, as you're evaluating your patients and they say, well, yes, I think I grind my teeth, and you say, yes, I think you do because I can see wear facets on them, but what do you do about it? We make them a bruxism splint, an appliance, and that's it, and we hope that they get better. But I think there's more to the story. Now, when you look at cervical pain, we're talking about pain in and around the patient's neck. And if you've got pain in your neck, how does that relate to tooth pain or tooth issues? Now, I was trained to treat to the teeth, and I was trained to fix the problems in the teeth, and I sort of had blinders on, especially as a young dentist coming out of school. I didn't see how those things were all tied together. And so if I had a patient that complained of neck pain, I would refer them out to their physician for an evaluation. And then stiffness in the backs and hips. If you've already told me that you have paralysis from polio as a kid, and now you're telling me that you have stiffness in your backs and your hips, I'm not going to even begin to help figure out why that might be related to your mouth. It's related to your polio, and that's not something that I treat. So we would ignore those things. Postural problems is another one. If I have a patient that walks into my office and one shoulder's higher than the other, or the patient holds their head in a funny position, I don't even know to look for it. If we did catch it, and I remember in gross anatomy with the medical students, we talk about the kyphosis lordosis, the natural curvature of the spine and of the neck. I learned it, but I didn't learn how to use it. And then we've got things like insomnia. You got a patient who has sleep pattern issues. As a new dentist out of dental school, it's not on your radar. One of the fastest growing fields in dentistry is oral sleep medicine. And when you're looking at some of the places that are leading that education, the Las Vegas Institute happens to be one of them, with the series of sleep programs that we have here leading up to a diplomate. It's a very phenomenal way to open up the doors in your practice and treat more of what's going on with your patients. But sleep hygiene and insomnia for my patients, coming out of dental school, I had no idea. But the issue is all of these things are tied together. When you look at what's going on with your patients, when you really take a look at how your patient's quality of life is being affected by their teeth, every single one of these has an impact. So we do get to some things that we see as dentists. TMJ, opening, closing, click. Finally, we have an issue that not only is it a dental problem like the loose teeth or the bruxism, but we can do something about it. When I was in dental school, what I was taught to do was to make them a bruxism appliance or a night guard. We would take upper and lower impressions, we'd take a bite, we'd send it to the lab, they would mount the case, and then they would adjust the articulator and send it back to us. Because we were taught that there's this hinge axis somewhere around the condyle, and so we could use that to design our prosthetics. The unfortunate reality is there is no hinge axis because there is no pure rotation movement in the condylar head. At any point in normal function, there is not a hinge. And so when we're trying to design an appliance that works based on a hinge, if there's no hinge there, then our appliance isn't going to work. And that is, in fact, what I found. I distinctly remember year and a half out of dental school, every time I'd get one of those back, I would end up delivering it to the patient and it wouldn't fit. Their mouth would be kicked open like this and they're just hitting on the back of it. And so I would grind on the back of the appliance and I would try and remove enough acrylic that we can get more teeth together. And 5 minutes later, I'm starting to perspire a little bit, that bead of sweat that reminds you that you're not exactly sure what the next step should be. And then another 5 minutes later, I'm covered in acrylic, which is sticking to my skin, and then my patient's covered in acrylic, and the two of us are both trying to figure out whether what we're doing makes any sense at all. And finally, I adjust it down so when we put it back in the patient's mouth, they tap, tap, tap on it, and they're hitting teeth on both sides, and they say, I don't know, I think it fits right. What's it supposed to feel like? And I realized that I didn't know. I don't know what it's supposed to feel like. I wasn't taught that part. I was taught that it was supposed to fit. And if it doesn't fit, I don't know what else to do. Well, in reality, we weren't taught the complete picture, and that's what's held us back. When you look at the way occlusion should be managed in a dental practice, it's such a simple thing to help our patients to explore better health through proper functional occlusion. But we weren't taught that in dental school. We were taught some things that just answer some of the questions and not all of them. And as you get the rest of the pieces, it starts to make a lot more sense, and that's what I think you'll find when you come to a program like we have at LVI, the Core 1 curriculum. In that program, it teaches you how that functional occlusion really works. It will walk you through the science behind why we have had problems with what we've been doing. It will walk you through the science behind why we end up in a bad bite. It'll walk you through the science behind how we help our patients to get into a better bite. So that's what ends up happening in a case like this. You've got a patient with a lot of different symptoms, and most of them don't even seem like they're dental, and we'll find out that they actually are. Now, looking at extra-oral signs, she had some of those too. Bilateral facial asymmetry. She had a difference, a mismatch between her right side and her left side of her face. Forward head posture, where the patient's head is actually out in front of the spine in a place where it shouldn't be. One of the things that we know, based on proper physiologic muscle function and load, if you have the head properly positioned on top of the spine, the way that it's supposed to actually fit, it should be about an 8 or 10 pound bowling ball. As you start to move that head forward of that proper position, you, for every inch you move forward, double the effective weight of the head. So if you've got a patient with a forward head posture that puts their cranium 2 inches in front of center, it's like a 30-pound bowling ball. And that's not a comfortable way to walk around. That will certainly cause some problems. And one of the things that we've discovered as we look at the science behind muscle physiology is 90% of the pain in the body comes from muscles. If we can diagnose the cause of the pain in the muscles, we can get rid of a lot of our patients' pain and discomfort. Forward head posture, it's a major warning flag, and that's something that everyone on our team should be looking for. Same thing with bilateral facial asymmetry. If you've got a patient that has a mismatch between the right side and left side of their face, there's probably something going on. We know form follows function. If the stress dynamics of the bite are such that it supports proper development, they should have fairly good facial symmetry. If the stress dynamics of the bite don't, form still follows function. You will end up with a mismatch, an imbalance in the force, and that imbalance in the force will cause the bones to respond. And over time, you'll see a patient whose face used to be straight end up shaped like the letter C. Major red flag, and that's something we all need to be looking for. Now, I wasn't coming out of dental school. I went to a great dental school. The dental program at University of Oklahoma is top-notch, but we weren't taught how to comprehensively diagnose patients because we're just still learning our tooth numbers. It's quite frankly too early in our dental careers, and that's the reason you need to continue to aggressively pursue your education. The more that you know about how the body works, the better dentist you can be. Now, taking a look in the mouth, we get into some things that feel more dental. You look at wear of the anterior teeth, and that's an easy thing to pick out. Now, the question is, how much wear is normal for a patient like Judy who's, mid-40s, mid-50s, mid-60s, mid-30s? How much wear is normal for a patient like that? I didn't know. I don't know what it's supposed to look like. I don't know how much wear you should have at 20 versus 80. I assume very little at 20, and is quite a bit of wear normal at 80? Well, I know better now. But I didn't know that coming out of dental school. Now, when you look at the discrepancies, the mismatch between the top and bottom midlines, that's a big, big issue. But how do we fix it? What do we do? What do we look at? And when is it important to fix midlines? If the midline is off on the top and it doesn't match the face, what does that mean for our patients? If the upper and lower midlines are within a millimeter of each other but don't line up precisely, is that okay? Well, yeah, I think it probably is. But I had no parameters as far as how to diagnose that or how to manage that. When I was coming out of dental school, I didn't even really know what to do if the upper midline was off, or if you have the Tom Cruise midline where it's crooked and way over here. What do you do with a patient like that? Well, you refer them to an orthodontist, I guess. Now, when you look at some of the other issues that we have, abfraction lesions, that term was coined during an ADA meeting when I was in dental school. So it's a fairly new term, but what is it from and what does it mean? Now, we were learning how to restore those. When I went to dental school, we were using amalgam. As I graduated from dental school, we were starting to use resins, and shortly after, we were putting in flowable resins because they bend and flex more. So as that tooth bends and flexes, the restoration would bend and flex with it, and it wouldn't pop out. But the question is, why is that tooth bending and flexing, and is that related to the abfraction in the first place? I'll tell you now, there's no question in my mind. Coming out of dental school, I had no idea what caused it. So we're going to look at all of these issues. Bicuspid drop-off is another one. When we were in dental school, I don't remember ever hearing the term bicuspid drop-off. But that refers to lower arch where you've got your lower anterior teeth at one level, lower posterior teeth at a different level. How does that happen? What does it mean? What do we do with a patient like that? I didn't know what to do in dental school. You can see clearly that the lower anterior teeth are a lot taller than the lower posterior teeth, and the lower anterior teeth are wearing. When I was in dental school, we talked about occlusion, but what we were really talking about is the tooth-to-tooth gearing. What we'll talk about at LVI as being the microocclusion, the interface between the upper and lower sets of gears. That microocclusion is critical. You've got to have those teeth meeting when they should, and how they should, and where they should, and with the intensity that's proper for the teeth. But that's all secondary to the macroocclusion. The relationship between the upper and lower jaws, the difference between where your lower jaw floats in space relative to that maxillary arch. If you can get that macro-occlusion correct, the jaw-to-jaw relationship correct, and then support that with the proper micro-occlusion, you can keep your patients comfortable. If you can't, the body will try and equilibrate and the body will try and fix it. So our challenge is to figure out what the macro-occlusion should be, what micro-occlusion would support it, and then help our patients to achieve that. And there are lots of different avenues to do that with, but we've got to be looking at the right thing in the first place. Now, when you look at some of the other issues like missing teeth, that's something that should show up as a dentist. You recognize that. You don't have teeth, but how important is it that you get those replaced? Is a removable prosthetic adequate? I was taught that it was. And I think that it is a fantastic interim functional appliance. I think it does help to serve a purpose. And if the patient can't afford a fixed tooth, if they can't afford to fix it with a prosthetic that maintains that solid tooth-to-tooth relationship throughout the arch, well, then a removable prosthetic makes sense. But the lifetime on those removable prosthetics is pretty sad. They're not comfortable to wear, and so the patients will wear them quite a little bit for the first few weeks and the first few months, but then that starts to fall off. 5 years later, unless it's a social reason, the patient's probably not wearing it, and if that's the case, what kind of damage is being done? In my mouth, I'm not comfortable with anything that's removable. In my mouth, if I had to replace a tooth, I would start with an implant first. I'd get a good root in there, and then build a crown on top of that. Patients deserve the opportunity to at least explore patients deserve the opportunity to at least explore the possibility of replacing their teeth with something that's fixed and stays in place. Not something that's removable, but a set of teeth on top and a set of teeth on the bottom that stay in place and that meet where they should and meet how they should. And so when we're looking at what dentistry can do for our patients today, we have so many opportunities that we simply didn't have 10 and 15 years ago. Our patients deserve the opportunity to explore the best first, and let's figure out what makes most sense for them after that. Now you look also at the top of her mouth, and she's got some minor rotation, crowding issues. She doesn't have a lot of stuff that really screams at you that, wow, this mouth is falling apart, but you do notice there's a lot of dentistry. Quite a little bit of dentistry was done in the back teeth, and was that all done so that it fits the proper functional relationship that each of those teeth should have? I think one of the things that certainly I've heard it from a lot of people that went to schools other than mine, but we kind of have two options when we're restoring a tooth. We either make it high and grind it in, or we leave it low and let it grow. And what kind of damage does that cause long term? You make one tooth that doesn't quite fit the mouth, and the mouth will accommodate to it. And maybe it grows into place properly, maybe it doesn't. We don't have any way to know. So what we want to do is we want to figure out how we can restore that mouth so that it is functional, that we know that it's right, and we know that it fits, and we know that it works. Well, that takes taking a look from a little bit different perspective. And that's what neuromuscular dentistry is about. That's what comprehensive care is about. Now you look at the choices that Judy has, assuming that there is the potential for an imbalance in her macro-occlusion, in the jaw-to-jaw relationship, assuming that there might be something wrong with the way that her lower jaw fits in space compared to the way that the rest of her cranium fits in space. That leaves us with a couple of different options. We can fix just the teeth, or we could fix the macro-occlusion and the micro-occlusion. Or, of course, one of the first things you could do is nothing, and that's what she had done up until now. Largely leave the bite alone, largely leave the functional needs of the mouth alone, and just fix the restorative needs of the teeth. But that's one of the options. Another thing that you could do is create an appliance that redesigns the way the upper and lower jaws fit. You fix that macro-occlusion with a removable orthotic. It would work just like a TMJ, bruxism, TMD treatment appliance. But what you do with it is you dial in that macro-occlusion so that the muscles are comfortable with where the bite fits. So another of the options that we have is to use this removable jaw repositioning appliance, and that could be used short-term, that could be used long-term. Another thing that we could do is, once we figure out where the bite is supposed to be, we could orthodontically fix the teeth. Now, we noticed in Judy's case there is a bicuspid drop-off. If the macro-occlusion, the jaw-to-jaw relationship, were off by the same amount as that bicuspid drop-off, then once we design the bite and we prove it with a piece of plastic that yes, this is more comfortable, yes, this does address her issues, then maybe we could orthodontically move those teeth into position and then support long-term comfort of not just the teeth, but also of the jaws and the muscles. So that would be another option, orthodontically move those teeth to the neuromuscular position so they support proper physiology for your patient. In Doesn't really do much for the cosmetics. It wouldn't fix the rotation, it wouldn't fix the crowding, wouldn't fix the missing tooth, and it wouldn't fix all of the wear and tear and the old restorations in whatever state of success or failure that they happen to be in. But you could fix the bite that way. Another thing that you could do is a full neuromuscular rehab. And here you would actually go in and restore the teeth so that they are supporting the proper microocclusion that supports the proper macroocclusion. You build the teeth, the shape that you have proven in plastic that holds the upper and lower jaws so that the patient's comfortable. You find what's physiologically correct for your patients. You support that over a period of weeks to months to sometimes up about a year. Getting your patient's body physiologically adapted to this new functional dynamic. And then once we know that all the symptoms that we need to address are addressed by this new bite, once we know that the patient is comfortable, once we can verify that subjectively with the patient, but also objectively by looking at the data, then we can move into something a bit more long-term. And orthodontics would be a great tool. In a lot of patients' cases, they're going to pick restorative. And that's what Judy ended up picking. Because you get the cosmetic and the functional gains, you're able to achieve both of those things for your patients. You can give them a lot better endpoint and something they can be happy with and proud of. So she chose the neuromuscular rehab. Now, in looking at the proper macroocclusion, because that's where it starts, you get the upper and lower jaws in the right position, then you look and see what's left behind. There's a space between those teeth. That space, that gap, is what represents the difference in where the upper and lower jaws and the supporting muscular wants the system to fit and where the teeth actually do fit. So, if we could magically add in the tooth structure that's worn off over time, if we could magically undo the functional change in the bones and in the tissues from the dysfunction Judy has been in through the years, if we could just undevelop the bite problem that she's developed over the last several decades, then that macroocclusion bite that we see on the screen is what's correct for her. The only issue is the teeth don't support it. Now, we know that the muscle's job is to close the jaws until something touches, and by and large it should be the posterior teeth to touch. If they don't touch, then the anterior teeth ultimately will, and that's where a lot of that wear and tear comes from. And so we watch this patient close down until something hits. In her case, we're going to give her an appliance that helps her to bite into the proper position, and she can stop closing where the jaws and the muscles want her to stop closing, instead of being forced to close until the teeth touch. And that's what the gap is all about. We're going to fix that gap for her, and we're going to build her into a better bite. So that's where we started. Now, another thing that we can do is we can take a look at the occlusal table of those upper teeth. It should be roughly parallel to a skeletal reference plane, something that we can easily identify in models. It's what is termed the HIP plane. It was coined in 1955, long before I went to dental school, and unfortunately isn't something I was taught in dental school. But it's a very predictable way to evaluate how level that occlusal table is. And you can look at the occlusal table relative to this skeletal plane. That skeletal plane represents the cranial base. It represents what that patient's head should fit like in the articulator if their head's on straight. Now, when we look at it, there's an obvious curve of Spee, curve of Wilson that needs to be designed into the teeth. However, there is no roller coaster open anterior bite. And you can see on this slide right here how there's a huge gap between the edge of the upper teeth and the top of that horizontal table. That gap represents an issue that she has to accommodate for. That gap between the upper teeth and the table is a functional problem that Judy has to make some kind of an adaptation for so that she can do the normal things that she does. One of them was the swallowing, the dysphagia, one of those things we talked about in the very beginning that we didn't even think to treat most of the time. We don't even diagnose most of the time, but Judy has to make an accommodation in head position and in tongue posture in order to create a seal in her mouth to close off that space so she can start a swallow, get past the voluntary part, and get into the autonomic part where the body just takes over. Now, because she swallows 3,000 times a day just during normal daily function, this is a major issue, and she's having to accommodate to this dysfunction multiple thousands of times a day. It would be better for her if we could help her to not have to do that, if the system actually just took care of itself. So that's one of the things that we'll look carefully at when we're evaluating our patients is that horizontal reference table. Does it make sense for our patients? And you take a look also at what we can do there is you wax the upper teeth down so that when you are looking at building this new set of teeth, they match what the proper cranial base should look like. They are built to the table with the proper curve of Spee, curve of Wilson built in so that you can get in and out of occlusion, but they're waxed down to the table so that you have an ideal level cranial base. You straighten out the dysfunction that the warping in her jaws have been causing all this time. And then on the lower, we're going to fill in that gap by waxing the lower teeth up so that they fit. So the gap that we saw in the very beginning of our diagnostic models in the neuromuscular position, in Judy's case, we're going to end up splitting the difference. We're going to wax her upper teeth down so we create the proper curves and the proper planes with the right horizontal level angle of her maxillary arch. And then we'll fill in the rest of what's left by waxing the lower teeth up into that neuromuscular position. And that will help to support her macroocclusion with a proper functional microocclusion. And if we can do that, then the idea is that Judy's going to be perfectly comfortable. Now, we would never jump into any kind of a case like this. Any case where you change a bite, you would never do a case like that without starting out first with testing the bite. It's one of the big issues with orthognathic surgery. The way that that's typically done is we make a big guess at how the jaws should fit together, then we sticky wax them together and make a surgical splint. And then we use that surgical splint to section the jaws, do your sagittal split or your Lefort, wire the jaws back together using that splint, and then we have the proper dental skeletal or dental relationship, but that doesn't do anything for the origin insertion, the muscle relationships. Well, you don't have a way to test that. You don't have a way to do a test drive in orthognathic surgery. You don't have a way to do a test drive on orthodontics if you don't start first by diagnosing that gap. So with neuromuscular dentistry, what we're going to do is we're going to use an orthotic to prove first that we can make an improvement for the patient. We can prove first that we can change that patient's life for the better. If we can't, you would never get into restoring the teeth. But if we can, then we also have made a diagnosis on exactly where we want the teeth. We know what kind of dynamic that we want to build that dentition into so that it supports macroocclusion and microocclusion, patient comfort, and quality of life. So here's Judy before, taking a look at her teeth and how her upper and lower jaws matched. And then, of course, here's Judy after, and absolutely there's going to be an improvement in aesthetics, but that's not really what this is about. What we're really looking at is the improvement in her symptoms. The polio paralysis was fixed. Well, not because we can fix polio, but because it was misdiagnosed. It wasn't paralysis from her polio. It was a paralysis because of an imbalance in the way that her muscles worked and an impingement on nerves. It was a paralysis that was left over from an inadequately supported functional dentition. And she had to make some compensations, and the body does compensate. In her case, it created a left side weakness. Well, we fixed that when we fixed the functional problems. We also fixed the head tilt, the dysphagia that she was dealing with in the beginning. That was fixed by eliminating that gap that she had to fill with her tongue. And she's able to chew her food now in a way that she never could before, because we've got the proper microocclusion and it's hitting at the proper macroocclusion. She's able to do very, very well. All of the symptoms disappeared, and of course, she gets a cosmetic bang as well. A lot of great reasons to comprehensively diagnose your patients, comprehensively treat your patients, and what we're looking at here isn't about doing full mouth cases. What we're looking at here is about doing full mouth diagnosis, helping your patients to see what's possible, and then allow them to fix or to select what's right for them. Help your patients to determine for themselves what they want, but we owe it to our patients to show them what kinds of things dentistry can do.